Good afternoon, everyone. I'll be critically appraising this diagnostic study. So it starts with a clinical scenario. Mrs. V, a 56-year-old lady who is admitted to a ward with a clinical diagnosis of acute pyelonephritis. She had a recent fall following which she had developed a neck of femur fracture and she had received DVT prophylaxis with unfractionated heparin at a local hospital. Subsequently, she is restarted on anticoagulation during her current admission. However, one day later develops respiratory distress and is diagnosed with a pulmonary embolism. Her platelets have also shown a decrease from baseline from 1.6 lakh to 60,000. So the question is, how would you proceed? Would you start her on a heparin infusion or switch over to a non-heparin anticoagulant suspecting heparin-induced thrombocytopenia? This is something that we usually do face in the clinical scenario. So to help us proceed, we usually administer the 4T score. So this is looks at the levels of platelets that are there. That is the thrombocytopenia is what is the fall in platelets, the time of the fall in platelets following heparin administration, the presence of thrombosis or any other sequelae that is there, and whether other causes of thrombocytopenia has been ruled out. Based on this, we get a score, and a score of 0 to 3 indicates a low risk, whereas 4 to 5 indicates high intermediate risk, and 6 to 8 indicates high risk. So the 2018 American Society of Hematology guidelines recommend you proceed with the 4T score, and then you proceed for a immunoassay testing for heparin antibodies if if there is intermediate risk, that is a risk more than equal to 4. So I will be critically appraising this diagnostic study, which is published in JAMA Hematology, and I'll be using the CASP questionnaire. So it starts off with the three main questions. That is, are the results of the study valid? What are the results, and will the results help locally? So did the study address a clearly focused research question? So this looked at the population with consenting adults aged more than 18 years of age with suspected heparin-induced thrombocytopenia. So the index test was, they looked at three things. So one was the 4T score, which I mentioned earlier. They looked at antiplatelet 4 levels, heparin antibody using the chemiluminescent immunoassay test, and a diagnostic algorithm combining both as we saw previously. So the comparator test was the gold standard, which is washed platelet heparin-induced platelet activation, the HIPAA test, and the outcome they looked at was the diagnostic accuracy. So the setting was that of 11, it was done in 11 tertiary care centers, that was in Switzerland, Germany, and the US. And the inclusion that they mentioned was suspected hit. So this was if the treating physician had ordered a platelet factor 4 assay or heparin antibodies, or they had applied a 4T score, or they had called the hepatology consultancy service. Exclusion criteria was those who had insufficient sample material, or there was insufficient clinical data that was available, or those who refused consent. So was there a comparison with an appropriate reference standard? So this is the reference standard the best available indicator? So the HIPAA test is again has a very high sensitivity and a specificity. It's a more of a functional test. So that along with the serotonin release assay, both are functional tests. They are considered the gold standard by multiple bodies. So essentially a negative test kind of rules out heparin-induced thrombocytopenia. So did all the patients get the diagnostic test and the reference standard? So were both received regardless of the results of the test of interest? So usually there may be some cases when there is a different testing strategy. So patients who get positive index, have a positive index test may not get the reference standard because either it may be too expensive or it may be unethical. So here we are looking at whether all patients who receive the index test receive the reference standard as well. So here it's yes. So we can look at the STAR-D flow diagram that is mentioned. So this shows that there was 1,448 patients who had suspected hit from 11 centers. They had collected clinical data, serum samples for the HIPAA test and the immunoassay, and they had excluded 55 individuals. Subsequently, they had come with the Toradi hit cohort, which is a larger cohort. And subsequently, finally, they had again excluded 75 individuals and come with a total number of 1,318 patients. So amongst this group, the HIPAA test was positive in 111 individuals, and the prevalence was around 8.4%. So could the results of the test been influenced by the results of the reference standard? So here they have clearly mentioned in the study that the data was collected by specialized nurses who are blinded to the results of the immunoassay and the HIPAA test, and only the data available to the treating physicians at the time of diagnosis was used. The lab samples were taken subsequently on dry ice and sent to a centralized laboratory where they were treated anonymously. So the 4T score at that point of time, there was less chance of a review bias. and as well as the immunoassay test, which is a very objective test with well-defined cutoff points. So what is the disease status of the disease status of the tested population clearly described? So here we're looking at what is the spectrum of patients that were seen and have they described it adequately. So here the patient characteristics, majority of the patients were male with the age median of around 67 years. They were predominantly from the intensive care setting and from the post-op cardiothoracic surgery wards, followed by the internal medicine wards. So the 4T score, again, there was low risk, equal distribution in low risk and intermediate risk. So a score of 0 to 3 around in 47% and in intermediate risk in 46%. So did they have thrombosis at presentation? So majority of them did not have thrombosis. Most of them, the ones that did have were other venous thrombosis or pulmonary embolism or DVT. So this is another thing. So then majority of the cases were actually taken from Switzerland. So three major centers from Switzerland. So you would expect that majority of patients are European by descent. Were the methods for performing each test described in sufficient detail? So here they've gone into great depths of describing how they collected the data, how they performed the immunoassay test and the HIPAA test. And it's been clearly defined, and it's very evident that you need a certain level of expertise to do these tests, and they're not easily available. So the sample size calculation, they used a method by Alonso et al. To find a difference in the specificity by 5% with a power of 90% and a two-sided alpha of 5%. So they'd come to a level of 700 patients that they needed to recruit. So coming to the last part of the initial section, which is, are the results of the trial valid? So they had a lot of pros and the study was done pretty well. So they had a focus question with an appropriate research reference standard and a well-defined study protocol. All participants had received the index test and the reference standard, nearly ruling out a possibility of verification bias. And there was an independent blind comparison. Cons or more likely remarks would be majority of the tests were done on patients in a tertiary care center in Switzerland, which might be different from our population. And the 4T score was calculated in majority of cases by the consultancy service. So it may have performed better than how it would do in real life if it was applied to a real life setting or a community setting. So coming to the results. So what are the results? So here we have a table that is comparing the 4T score, the immunoassay test, and the recommended diagnostic algorithm. We see that there is some amount of false negatives that is there, which is a bit alarming. So 9%, and the recommended diagnostic algorithm has around 13.5% false negatives. And the sensitivity, specificity, and the scores are mentioned. So it seems that the 4T score and the immunoassay test is highly sensitive, but the specificity of the 4T score is slightly lower. It's only 50% with a very low positive predictive value. So we'd like to, again, just show how we came to those scores, how the study also comes to score. We can do it ourselves by using a 2x2 table. So on the top, we have the truth. So those are those who have the disease. We have those who do not have the disease. That's the true positives, that is A, and then false positives is B. And the test scores positive and negative. So we can include the data that is there. So I'll be looking at the diagnostic algorithm that I mentioned. So hit positive and test positive is 96. Those are the true positives, whereas the true negatives was 1,157. So we have the rest of the false negatives, which is 15, and the false positives, which is 50. From this, we can calculate the sensitivity, specificity. For sensitivity, we just go down this way, true positives by true positives plus false negatives, whereas true negatives divided by true negatives by false positives. So we get a value of 86% and a specificity of 95%, positive predictive value of 65%, and a negative predictive value of 98%. So subsequently, we can calculate the likelihood ratio also, which would help us to incorporate it in clinical practice. So the likelihood ratio is a positive likelihood ratio is the probability of the test being positive in a diseased individual as compared to a non-diseased individual. So that would come to around 21, whereas the negative likelihood would come to around 0.14. So ideally, usually a good test, if you would have a positive likelihood ratio of more than 10 and a negative likelihood ratio of less than 0.1. So as clinicians, you would notice that for any case scenario, there's always a pre-test probability before we apply a test. So if the probability of this patient having a heparin-induced thrombocytopenia is close to 65%, if the test was positive, that is, if I have put it at 20, so the likelihood ratio of 20, then you would get a post-test probability of around 98%. And if we started off with 65% and it turned out to be negative, then we could it will come down to 20%. So that would effectively rule out possibility of heparin-induced thrombocytopenia, but significantly reduce it. So this is a receiver operating curves is also mentioned. So this is helps us show us how well the test performs or how accurate the test is in differentiating disease from non-disease individuals. So ideally, we'd want a cutoff point that picks up below which we rule out all disease and above which we can say, okay, these people are diseased. So we're looking mainly at the area under the curve. So as you notice, as the area under the curve reaches close to 1, we see that the disease and undiseased, non-diseased people are moved away. So we are looking we need a maximum area under the curve is what we're looking at. So the receiver operating curves for 4T score is around 81.3%, and for the immunoassay it was around 97.7%. So how sure are we about the results? They have mentioned confidence interval as well. The consequences and cost of alternatives performs, they have not specifically mentioned, but it's easy to impute. If the patient was false positive, that is around 4.1%. Those that didn't have the disease, without the disease, had a positive test, the consequence would be an additional cost by switching to an alternative anticoagulant, whereas false negative would be potentially life-threatening complication by continuing heparin. So coming to the third part, will these results help locally? Are we able to apply this to our population? So the prevalence in India is close to around 3.8%. This is from a multicentric trial that was cross-sectional study. Might be slightly higher in cardiothoracic patients. So again, if you impute the same values with the prevalence of 3.8, we get a positive likelihood ratio of 20, negative likelihood ratio of 0.14. And so positive predictive value is not very great, but a negative predictive value is 99.45. So if test is negative, patient does not have the disease. So can the test be applied to our patient or population of interest? So already we use it on a day-to-day basis at a tertiary care level. At the community level, access to platelet factor 4 testing may be difficult. And for the 40 score alone, if you calculate, it looks like it has a reasonably high sensitivity, around 90%, but the specificity is poor. And positive likelihood ratio is only 1.86. So based on your pre-test probability, it may not really change after you apply the test as well. But again, this test is mostly clinical with a few lab parameters. So it may help us, it's got a high negative predictive value. So it may help us in ruling out the disease, but not ruling it. So were all outcomes important to the individual or population considered? So other risk factors for heparin-induced thrombocytopenia, presence of malignancy, obesity, major surgery, autoimmune conditions, what happened to those patients like mortality, those are not mentioned. So what would be the impact of using this test? It's already being used in CMC, and in a resource limited setting, if you apply the 4T score alone, in the same patient, if you had started with the pre-test probability of 65%, and it would slightly go up to 75%, which may not help much. But if it was negative, then the post-test probability would come down to 20%. So back to our patient, what would we do if the patient had a high, so this patient would have a 4T score of around 7, and subsequently if the immunoassay test had come positive, then we would switch to a non-heparin anticoagulant and make sure that she's off heparin lifelong. Thank you for your patient listening.